It is a particular pleasure to introduce this panel, not only because thematically it is a topic that we have been focusing on. For the last year, we focused on this general theme of Africa 2060. There's no magic in the 2060 beyond that it's a nice number if you are in 2010, 50 years from now, and a way of forcing ourselves to think not only in the immediate but in the longer range in terms of Africa. All across last year, we did various activities around it. We've published, I think, 7 papers now on various aspects, things to do with Africa. We will be continuing that, even though at a slightly lesser pace, over the next year, even as we pick up on other themes. So this is one of the panels in that series. And it is a particular pleasure because all 3 of our speakers have written or are writing something for our publication series. Our first speaker is going to be Astier Almedom, who is at Tufts University and who was the author of one of our recent papers called A Call for a Resilience Index for Health and Social Systems in Africa. And there should be copies of the paper available if you want to pick these up. Our second speaker is Alfredo Burlando, who has just finished his PhD from the Department of Economics here at Boston University. Congratulations. He has been a Pardee Research Fellow all year, still is, and as of the middle of this month, he joins the faculty at the University of Oregon in the Department of Economics. So congratulations all round on that. He was actually one of the main organizers of our conference last semester called Good News from Africa, and is one of the authors of the report of that, which should be coming out fairly soon. And our third speaker is Melissa Graboyes, who has also recently finished her PhD here at Boston University, who was the author of an earlier Pardee Center Issues in Brief called Learning from the Past, the Future of Malaria in Africa, and who will also be joining the University of Oregon. And if you're wondering, yes, there is a connection right there. So in all those reasons, we are very, very happy. I'm also very delighted to see a number of people from the medical campus. It is a bit of a trek to come from there, and we are very happy that you were able to make that. We want to have a discussion on the future of health and development. We have 3 people who come at it much more from a development side than from a medical health side, but we have people in the room who also look at it from that angle. And what we have agreed to do is to maybe start with about 7 minutes or so of opening remarks from each of the 3. And then we will have a conversation with the audience as we have at these seminars. So with that, I will ask Astier to start us off and thank her for being here.
Thank you. Thank you very much, Adil. I'm deeply honored to be part of the Pardee Center House seminars, and especially to come to contribute something that Adil does, because he's a very esteemed colleague of ours from the Fletcher School before he came back to BU. So thank you very much for inviting me. I might say a few words. 7 minutes is not very long, but I thought the background to the brief paper that I prepared when Adil invited me came out in 2009 in October. It was quite old already by then, because this call for a resilience index was something I was advocating back in 2007. We had an international resilience workshop at our European campus in Tarwa, and that's when I first proposed it. So the first thing for me to do was to say, what exactly did I mean by resilience? You know that it's a very commonly used term now. It's become part of our everyday language in response to disasters, be it the oil spill maybe, or Katrina before 9/11. It's become more used in this country than it was before. But my beginning of researching resilience was actually coming from the people in the field that I came to study. Back in 2001, I traveled to Eritrea with a team, including Ministry of Health, Community Development, my own graduate student from Tufts, because my sense was I needed to see what the psychosocial fallout might have been from the then recent conflict on the border with Ethiopia. So by the time I arrived, people had, of course, moved on. So no one was going to be talking about trauma. There were displaced people in internally displaced person camps, but they were saying to me, why would we want to talk about trauma? It's taking us back to the position we left, because we are now here, we are doing well. So you might as well ask how do we survive against the odds? So I thought that sounds more positive. I'm glad to hear you had a good news from Africa conference recently. But that's what you find when people are engaged in adversity or trying to make sense of it. It's not the negatives they dwell on, it's the positives. So I decided I should find out how to measure or assess this in a scientific way and how to define it. So by 2007, I had defined it, as you saw on the brief paper. It's the capacity for, basically it's a multidimensional construct. So I see it not just as human individual resilience or ability to bounce back from trauma, but the capacity to anticipate and to keep functioning as normal. In brief, that's what I saw in the field, what my findings were showing. So by 2007, I could actually crystallize it into one definition, and I know you'll find many other definitions of the term in psychology, maybe in ecology as well. So by 2008, I had linked up with the Resilience Alliance sense of what they mean by resilience, or social ecological resilience, which in their terms means the amount of time it takes for the ecosystem to recover and function as normal. So it could be the length of time that you're measuring. In my sense, I was trying to measure the sense of coherence. It was a construct I borrowed from a medical sociologist, Aaron Antonovsky. Maybe it's familiar work to some of you coming from public health. But his idea was, how do people manage stress and stay well? So instead of asking, why do people get what makes them ill and how can we fix it? And this may be interesting to talk about later on about malaria. You have to treat it. You don't say, how do they manage with it, and just watch them. But instead you can say, given that this is a complex, highly stressful world, how do people make sense of it and manage and function as normal? And normal may be different for different settings, because it's different levels of stress and different stressors that we have to adapt to. So in my thinking as a biological anthropologist deep down, although I call myself just applied anthropologist, and I've been working in non-anthropology departments ever since my doctorate. So I worked in the London School of Hygiene Tropical Medicine, in the National Health Service of the UK before I came to Tufts. So any anthropologists in the room, please don't get offended that I'm not a Puritan, but I'm very interdisciplinary and applied. So in my sense of thinking, adaptation is also key to resilience. So if you adapt and can function as normal or productively without recognizably losing your identity as either as a system, as a community, as an individual or family, or the ecosystem, then you can be said to be resilient. And I found the sense of coherence scale quite applicable scale or a concept to study this. We have published, my team and I published, interrogating the scale and the findings from Eritrea, because we found that to make sense of coherence, you have sub-components of the scale which define comprehensibility of adversity. So to the level to which people can understand what's going on is critical. So comprehensibility, manageability, practical ways of managing the adversity, and above all, meaning making or meaningfulness. How, in the end, does it really make sense to engage with adversity, or would you rather just abandon it and shut off, or just descend to despair, or do you keep going because this is something meaningful? So I found those three subscales made sense. People were engaging with the scale as much as we were wanting to find information from them. So this is where it began quickly. And then, since then, it's led me in a very organic, evolutionary kind of way, and participatory, because we have to keep responding to what the findings say, what the respondents really meant. It's led me to discussions of peacekeeping and our idea of peace as not the absence of war, but something more positive. Because if you define peace as only the absence of war, it's negative peace. And I ended up collaborating with the University of Innsbruck in Austria. The Peace Studies program there has a UNESCO chair who has edited the International Handbook of Peace Studies. So one of my papers is in that, including discussion of resilience as part of adapting in a productive and positive way. So it's part of maintaining and sustaining peace. Another angle it's going is on systems and complex adaptive systems. That may be a familiar term to economists as well. And there is work done by Samir Rihani in the UK. Maybe some of you are familiar with him. It's a different definition of development than the traditional one, because he thinks development should be evolutionary. So you have developed incorporating learning from what happened before, whether it's a catastrophe or not. And in the process, it's a dynamic, non-linear, complex evolutionary construct. So in his sense, the UK is a developing country, for example, because they do transform and evolve by learning from experiences, whereas Afghanistan may not be a developing country because it's trapped in conflict and sustained stagnation of, if you look at it deeply in this sense. So I guess I'm now in the multidimensionality stage of the construct, and the end goal of this work is to find, maybe not quite as simple as we would like, but an index we can use to look at systems and subsystems in Africa and other places to see how resilient are they, meaning how much can they anticipate and engage and transform themselves after experiences of disaster, rather than be completely going in the wrong direction, like a downward spiral. So that's where I am, and maybe 7 minutes are up, I don't know. So thank you for listening. I'm really looking forward to what you are going to say. Thank you.
Great, thank you. Thank you all for coming. It's a pleasure to be here. I will take a step back and provide a more general overview of what I perceive to be health from a development perspective in Africa, and in particular what I perceive to be the future of health in African countries. I'll present a couple of, first I'll start with some trends on currently of health, and then some sobering facts that might make you think that things are not going particularly well or will not go particularly well for the continent. But then I will switch back and provide some why I believe there are some reasons for hope for the continent. So let me start with just pulling out some numbers for you. This is data that came from the Millennium Development Goals, and they've looked at there are some very good positive trends for health in Africa. So since 1990, under 5 mortality rate, for instance, has declined by around 20%. Bed net use have increased from from 2% to around 20% of children who now sleep under a bed net. Maternal deaths have been declining. Use of antenatal care has been increasing. Population using improved sanitation, such as latrines, have also been increasing by around 80%. Similarly, the population that use unsafe water sources as water for drinking have been declining by around 17%. So these are somewhat positive trends. Most of these, it's encouraging that a lot of these have been accelerating in the recent past. And so these are good things. Nonetheless, obviously, Africa remains the most unhealthiest continent. It's the indicators that I just mentioned to you, while moving in the positive direction, have been moving to in a faster pace everywhere else. So Asia, Latin America, Oceania have increased and made strides at a faster pace. So Africa does remain a laggard and continues with being behind the rest of the world. So what I wanted to cover in this discussion is, are these trends sustainable, and can Africa actually catch up? What I want to first mention are a couple of additional facts that make you think that that's not going to happen. One is, of course, that the medical structures that are present in most of the continent are seriously lacking. A lot of people are not using hospitals. There's lack of infrastructure, medical infrastructure, lack of medicines. There are problems with human resources. There's not enough doctors, and even when the country produces doctors, sometimes it's hard to keep them in place. And so there is some notion out there. I believe it's a fact. I'm not completely sure, that there are more Malawian doctors, for instance, in the UK than in Malawi itself, because they get hired away from Malawi. And so this is the first big challenge. And the second big challenge is that the disease environment in Africa is difficult. It is much more, it's heavier than in the other continents. The diseases that are present in Africa are entrenched in the environment. They don't have easy solutions. HIV/AIDS, for instance, is a big case. It started in Africa. It doesn't have there's no vaccines to prevent it. And 67% of all people that live with HIV/AIDS live in Africa. Another big disease that I've done work on is malaria, and that again, it's a disease that is particularly entrenched in Africa. Africa has more deadly strains of the disease than any other continent. Has the largest variety of very powerful and effective mosquito transmitters of the disease. And it's such a difficult situation there that when they did eradication attempts around the world in 1950, they just skipped Africa. It was just going to be a little bit too difficult for them. So, and this is a disease that I came to respect significantly in my own work, looking at Ethiopia and looking at the variation, looking at differences in health, in average health across villages, and the entire variation of village health across different elevations could be explained by malaria itself. Okay, so they had just such a significant shifter of overall healthiness in many parts of that world. And the implications for the long run, of course, I'm actually feeling a bit positive, despite having said all of this. One, because medical infrastructures are being built, will continue to be built, and that's a process that will continue. And even if these diseases that I just mentioned and others that are on the rise in the continent, even if they remain and they're not possible to be solved, simply put, they can be managed in the long run simply by having higher average spending on addressing these diseases than any other continent. So overall, I think for Africa, it is possible to keep low morbidity. They will just simply need to have higher levels of spending than other luckier countries or continents. There are some helpful trends that I wanted to highlight in terms of increasing average healthiness of the continent. And I want to talk about the ones that, there's lots of trends, but I want to talk about the ones that are interesting to me. One is the effect of economic development on health. And the second is the innovations in healthcare, that are innovations that are specific to Africa, or at least specific to the developing world. And I'll be quite specific about what I mean by those. So economic development, so first of all, Africa is growing. In terms of the economy of Africa is growing, and that is, I think, going to be the key determinant of the key driver of health for the continent. Development and economic growth leads to better medical infrastructure, leads to more health spending per capita, leads to better education of the underlying population, and of course of doctors. And so you will have, there's more medical training, and there is a more awareness of what populations need to do to keep themselves healthy. So just by itself, those things will be driving health. There is also an indirect effect of development on health that I've been focused in my research. So one of the interesting things that I found that in working in Tanzania was that in these countries, even if you keep everything, medical infrastructure constant, and all stock of medical care constant, just the better infrastructure can lead to better development, to better health. So, for instance, I analyzed a specific event, a month-long blackout in a specific region of Tanzania where the power was cut, and I showed that in this place that is poor, underdeveloped, this single event led to significantly lower birth weights and a 30% increase in the number of children that were born with low birth weight. These being children who were born out of mothers who were pregnant during this blackout. And so why? Because this blackout, of course, had a significant effect on income, and that translated into lower birth weights. You would not expect this pattern to take place in a country that is wealthier. Why? One, because richer nations do not have blackouts that last for a month. That simply doesn't happen. And that's an important point. A lot of countries in Africa do have these kind of events. And secondly, because birth weights just do not respond to these kind of shocks elsewhere. Families with wealth are able to create buffers that take care, are able to smooth these kind of income constraints, income shocks relatively easy. So that's a key point, the key driver, I think, for that will drive health. The second one that I wanted to talk about is the economic innovations in health and healthcare in the continent. This is not work that I've been doing, but it's something that I've been hearing about recently. I find fascinating. And the issue here is just not to have better public health systems, but ways to actively engage this population in increasing or taking better care of themselves. So this is important in a place in Africa where there is little institutional development for health, and so there is little capacity to monitor the population and make sure that the population does not engages that diseases that could easily spread do not spread easily. Okay, so how do you actually engage people, and how do you create the system of a system that is that allows people, or that forces people, or suggests people to really change their behaviors? And what we as economists have looked at are incentive systems. So how do you incentivize people to change their behaviors? The key example here would be the experience of Mexico with Oportunidades. That was a program that was established, I believe, in the 90s, where families were paid to take care of their children, to make sure that they go to the hospital, to make sure that they actually go to school. And this program, in Africa, that has taken a whole different dynamics. And right now there are interesting research going on, experimental programs which involve paying people, basically, to make sure that they get tested for HIV/AIDS. So if you go and get a test, you'll get a little payment. Or even paying people to have engaging in behavior that will reduce the transmission of HIV/AIDS, such as safe sex, by, for instance, paying them, testing them every so often, and paying them to if they remain free of STDs. Okay, those are a couple of interesting examples. I think as economists, we'll probably take this concept of incentivizing people too far. That's what we generally do. These are potentially cost-effective ways to improve health and introduce behavior that is conducive to better public health. I will just conclude by saying that as well as these other things, I think that these micro-incentive systems are likely to play an increasing role in health in Africa because of the spread of IT technologies, such as cell phones, that allow to either disperse the payments to a wide population, follow people from far away, or so in a sense monitor the population through cell phones. And we actually had on the conference on Africa 2060, we did have a speaker that provided several examples of how cell phone technology can be used today in healthcare. So in a sense, to conclude, I remain hopeful, and I believe that in a sense, health in Africa is in an upswing at this moment, and I'll leave it at that. Yeah.
Thank you. Thanks, Adil, for inviting me to participate. So my name is Melissa Graboyes, and Astier said you trained in applied, or you consider yourself an applied anthropologist, but you asked for some leeway from anthropologists in the group. And I guess I trained as a historian, and I also received my master's in public health with emphasis in health law, human rights, and medical ethics. And today, I'm definitely not talking as a historian, so I should be considered a heterodox historian today, and a little bit from the public health hat, but really talking from a learned anthropologist from the field, from doing field work in East Africa for a few years. I want to talk a little bit about my current research, which is a history of human medical research in East Africa, so medical research, human experimentation, and medical ethics that go along with it. So my project was primarily historical, looking from the period 1940 to 65. But what I want to talk about today is the medical research that continues to go on in the East African countries of Kenya, Tanzania, and Uganda, and present you with two kind of paradoxes and two big trends that I see going on with medical research in the region, and that I think have larger implications for the African continent, but definitely for other parts of the developing world. So when I say medical research, I mean research that relies on humans. So things like drug trials that go through multiple stages where you have to test to see if the drug is first not toxic, second if it's better than nothing, and third if it's more effective than available treatment would qualify as medical research or human experimentation. Now, East Africa, it's more relevant to think, or it's more important to think about these issues in the developing world because it's typically cheaper to do this type of research in the developing world, especially in East Africa. There's an ease of doing it because you have more pliable populations, and typically the national laws are less stringently enforced than they are here in the United States and parts of Western Europe. And what I say about East Africa, that's really what this talk is going to be grounded in. I think it can be true for other parts of Africa. I have not worked in West Africa, but I know like in Senegal and the Gambia, there are large amounts of medical research being done by the Medical Research Council in the UK, and that's been going on since the 40s and 50s. In South Africa, there's huge amounts of medical research, yet they have a much more advanced medical infrastructure than other parts of the continent. And in other parts of the continent, like Chad and Sudan, I would say there's very little medical research on an international level going on. So the first big theme, trend that I see is that, that's also a contradiction, is that pharmaceutical developments, new drugs coming out, are a very real positive development on people's health. However, there can be a very huge discrepancy between the benefits of health gained by those using new drugs and the risks borne by those who are asked to participate in medical research trials, who are typically called subjects. So the facts are that in East Africa, so this three-country region, this is the most heavily used region of Africa for medical research, and it's actually growing very quickly. I'm not quite sure why, and I haven't seen any definitive statement on why. I think it's partly a language issue, that there's some hospital infrastructure, it's a peaceful region of the country, and that there's been medical research going on there for more than half a century. Also, most of the drugs being tested in East Africa at this point are not relevant to the local disease environment and health conditions. So there are malaria drug trials, there is the odd nutritional vitamin supplement study going on, but a lot of the trials going on are related to lifestyle diseases in the industrial world. So these are cholesterol and heart disease and viable drugs, important drugs, but not necessarily super relevant to the conditions being borne by local people. And then the third point is that rarely, when drugs make it through all the stages of development and they become available, rarely do they become available in East Africa. And when they do become available, the cost is often prohibitively high that they're not available to the very people who would have participated as research subjects. So the question that I ask as someone who worked in East Africa and did a lot of interviews with both medical researchers, past and present, and East Africans who worked as who participated as research subjects, is what are the benefits that East Africans who work as subjects, what benefits do they get, and what are the risks they bear by participating in this research? And I think that this raises important questions about ethics and human rights and kind of equity for how new drugs are developed. And while I was out doing interviews in the northern part of Tanzania near the border with Kenya, I did an interview with a medical researcher who had been working, a Tanzanian man who had been working for about 35 years. And he described to me when he would go out with an experimental drug into a rural village and offer it to people, that the question he often got from villagers was, is this dawa or is this not dawa? And dawa is the generic Swahili word for medicine. And what people wanted to know was, are you giving me real medicine to cure the malaria I have, or the diarrheal disease I have, or the respiratory infection I have? Or are you giving me something else that I can't quite put my mind around? And if it's something else, why are you giving it to me? And I think this is a paradox that continues into the present, with people not always being certain what they're being given, and there not always being tangible benefits to offset the risk of participation. So this leads into the second kind of trend, which is also a little bit worrisome, which is that medical infrastructure and the medical systems working in these three East African countries aren't really functioning by, I don't think, any measure of the word. They're not, by expenditures per person, it's only a few dollars per person per year. The services provided are few. You go into rural areas, you find many dispensaries without drugs or without trained professionals. And also by public health indicators. So, I mean, Alfredo talks about there are positive developments, the Millennium Development Goals, advancements are being made, but compared to any other continent, it's not a functioning healthcare system. So if that's the case, it also has to be balanced with the fact that international medical research projects, legally, by US federal law and by international treaty, must provide some tangible benefit to anyone who participates in a trial. And this benefit is most frequently given in East Africa by providing access to basic medical care. So this would work by you sign up for a phase 1 or phase 2 trial of a drug to test toxicity or whether it's actually more effective than nothing. And in order to compensate you for your time and your participation, we'll give you money to get back and forth on the bus to our facility. But we'll also say that if you get sick anytime while you're participating in this trial, you can come to our facility and you'll be seen by a doctor. So a primary care physician, and they'll have access to basic drugs, basic antibiotics, maybe malaria treatment, oral rehydration salts, maybe antibiotics for respiratory issues. And that is your benefit to participate, basic medical care. Now, US federal law and also international treaty, the Nuremberg Code, developed after World War II, and the research done by the Nazi Germans, was that whenever people participate in medical research, legally they're required to give informed understanding and voluntary consent. And that means that they've been informed of both the risks and the benefits, they understand what those risks and benefits are, and that they feel able to make an honest decision between either participating or not participating. So one of the questions that's been raised by medical ethicists, by medical anthropologists that I've thought a lot about, and people working in the field, I know a lot of public health people, is whether offering people access to basic medical care in a place where they do not have access to it otherwise stops a person from voluntarily, willingly participating in a project, because the conditions and the offer itself is coercive. And the reason I got thinking about this was while doing interviews out in Western Tanzania near Lake Victoria, I spoke with an older woman who recounted when the vaccination campaigns for smallpox were first being done in the 1970s. And this was a very new thing, and people were very worried and unsure whether this was experimental or how effective this was. And I asked her, did you ever worry about bringing your children to the clinic and having them vaccinated? And she said, in the face of a disease, what mother could refuse? And I think that that captures exactly the idea of what could potentially be coercive about offering basic medical care. In the face of a deadly disease environment and epidemic diseases where people do not have access either to the drugs or the means to purchase those drugs, offering something as simple as a vaccination or access to malaria drugs that may only cost a few dollars could be coercive, because that mother herself said there was no way she could turn down that offer. More recently, on the Kenyan coast, a group of medical anthropologists working with the Kenyan Medical Research Institute, they were also doing a malaria drug trial. They offered a free clinic to anyone in the village who wanted to come, so you did not have to participate in order to bring your child and access medical care. When they interviewed the mothers and asked, why did you decide to let your child participate? The mothers said, well, we wanted our children to have access to this care. The interviewer followed up and said, well, you know, you can access this clinic no matter what, even if you said no. And every mother said, this is what they say, but I know they'll treat my child differently if I don't participate. So every single mother who chose to participate did it not because she understood the risks or benefits. She did it because she thought it was the best medical, the most logical decision in a very harsh disease environment. So I think that for the future, there's no reason, I believe, that there's going to be less medical research in the coming years. It doesn't seem to indicate that from the pharmaceutical industry. East African governments don't seem to indicate that they're going to be more circumspect in allowing in particular projects. And I don't think that there's any reason to think that state-provided health services are going to improve dramatically in the near future, where most or all citizens are going to be covered by basic primary health care, and thus an offer like those given by the researchers would not be construed as coercive. And then finally, I think that it's right to think with these two things together that more East Africans are going to be involved in medical research without access to significant benefits beyond this individual health care. And that one of the things we need to think about is that the real improvements that come to health from these individuals who choose to participate in medical research projects, so access to malaria treatment or access to basic antibiotics, whether that's worth the risk to the population at whole and jeopardizing the idea of voluntary consent for medical research projects in general. So that was very general, not historical, but I think I'll leave it at there and we can take questions.
Thank you. Thank you very much. Thank you for those three very, very distinct and all very interesting perspectives. And we'll open it up for questions, comments. Please feel free. We have a lot of people in the room who have a lot of experience in the continent in health issues elsewhere, so please join the discussion. Just let us know who you are. We have a mic if someone wants to raise. While I should also mention, I'm delighted that we have so many people joining. I do apologize for those who came and we had run out of food. We will make sure we do better next time. But I'm delighted to have people here. Anyone, comments, questions? While you think, maybe I can throw one at Astier and then open it up, and maybe the others can also join in. I've been fascinated by the idea of the resilience and measuring resilience, and I know sort of we don't have an index per se which places numbers, but having heard what you've heard and having looked at the continent deeply for long, how is Africa doing on resilience? That may be the unfair part of the question. And more importantly, what do you think can be done in terms of policy to enhance the resilience of communities? Because this happens at a community level, doesn't happen at a state or continental level.
Right, yes. Thank you, Adil. Yes, a quick response to your provocative question, how is Africa doing? We are trying to tell a different story. It hasn't been told yet. What I heard from Alfredo and Melissa both is telling more about the vulnerability, even though Alfredo was stretching it a bit to say, I'm in the end very hopeful. I thought, okay, that could be insulting. It could be patronizing to people who don't think it is hopeful if you present it in the way you did, because it's we are looking at vulnerabilities and we are not looking at the systems that create vulnerabilities. And why in my paper, in this short brief paper, I remember including a little bit about the healthcare workers drain out of Africa. So if Malawi is exporting the best trained doctors, I have colleagues in Makerere in Uganda training the best pediatricians, all other descriptions of medical profession, and they are being employed elsewhere because they get paid more. So in fact, one of the discussions we had, this is ongoing discussion, we need to say, how are the communities and countries in Africa doing in spite of all this? So that's where the question starts. And if we do that, then we look at social capital, the systems of support that keep people intact. Some of it is contradictory because the people who get employed from Uganda by, say, the UK or the US hospitals will be sending remunerations back to the communities that have low income, the people that worry Alfredo. So in fact, this is at the same time supporting some resilience, but in the end the system is being eroded of its resilience. So one of my references was taken from the series in the Lancet journal that came out back in 2008. There was a discussion about should active recruitment of health workers from sub-Saharan Africa be viewed as a crime. We should maybe stop recruiting, but instead give incentives for the hospitals, the medical schools to retain their health workers, the human resources, because what Africa has is human resources. We should not be depriving them. And along that line of thinking, there are countries, top of them is, top on the list is Norway, which has a policy, actively implemented policy, not to recruit anyone from Africa to run their own health system. Instead, use Norwegian or other health workers for the Norwegian systems and support the systems like Uganda, Kenya, Tanzania, other parts of Africa that are trying to retain their health workers. So I think there's so much that's reversing. And let me say just one more thing about the Millennium Development Goals. Okay, by 2015, we are supposed to reduce poverty. But last year I was discussing this with my students in the European Forum at Alpbach to say, what if the Millennium Development Goal said, instead of reducing poverty, we should control greed? That's something, that's a different question. And I think people are asking these kind of questions. They're not only because of the economic crisis we had, where we think it's important to control this kind of greed because it's gone way over the top, no regulations. But in fact, if you started asking questions like that, you'll find these systems of community that runs with its own social capital, systems of trust, reciprocity, shared norms and values would not be in conflict. They would not be trapped in situations of conflict because of lack of for want, but instead they would be building sustainable, not based on greed, because you can't have development to infinity. So I would like to hear actually from Alfredo, how do you define development? Is it a straight line going all the way up to infinity, or is there a way down? Is there a way to return resources back to the new generation? Does it just accumulate until it collapses and then you have the worst of two worlds. You have the rich collapsing, but the poor are still poor too.
Melissa and Alfredo, before we open up, any reactions to?
Well, I guess I should.
We
You know,
have some
those are
comments.
tough question to answer, and of course, so 2 points. Clearly, the situation in Africa is not good. So you know that.
But according to whom, if you say to the Africans,
the
they will say
indicators. I
we
mean,
are
if you look at comcomparison,
Okay.
what you can do is compare.
So
and
we
look
are
at,
agreeing that it depends on the indicator.
Sure, but
Yeah.
morbidity, mortality, life expectancy, these are all good indicators that indicate that Africa is a laggard behind other continents. I guess what I wanted to just point out is that the trend is hopeful. And what I mean by development is, I guess behind in my head is a similar path, the future being that Africa will follow a similar path that other developing countries have been following for the past 15, 20 years, Latin America or Asia, meaning a progressive decrease in poverty rates, an increase in average income per capita, and a progressive increase in all social indicators and in human development. How sustainable is that? You know, again, I think in the long run we're all dead, so we'll have to see. But it is possible that at some point we'll hit a wall. I just don't know that. You know, and that's a question that I won't be able to answer. I think people who work on the environment will point out that we're, you know, maybe we're in deeper trouble than economists like to think. But.
And then there is lots of discussion on growth versus development.
Yeah, sure.
Sure. Both are complex phenomena. Before I open up, Melissa, any comments on any of the others?
No, I'm going to pass.
I'll open up. I have a couple of questions here. One of the thoughts, though, that struck me on the Norway example and this issue of exporting talent, since I'm a culprit, I guess, there, is one of my favorite development numbers of all times is from South Asia. I'm from South Asia. So if you go to a US medical establishment, if you want to find a South Asian in the US, the easiest thing to do is to go to a hospital. But if you go to US medical establishments, you will find doctors from all over the world, from Malawi, from Pakistan, from India, from Greece, from Ireland. But here is the wonderful statistic. The average American in America is more likely to see a South Asian doctor than the average South Asian in South Asia is likely to see a South Asian doctor. Now that's in the denominator, really. If you think about it, there are actually lots of doctors in South Asia, but there are also lots of patients. But I won't get into it today. I'm not fully sure that the cost benefit of that is one way, because the export of physicians certainly also has some benefits, at least in the South Asian example. Now, I'm not sure if it overweighs it, and I'm actually quite sure that it probably doesn't. But an interesting question that transcends Africa. Pablo, and if you can introduce yourself just so that for those who do not know.
Pablo Suarez, thank you. I'm Pablo Suarez, a fellow here at the Pardee Center, and I also work with the Red Crescent Climate Center. So a question and an invitation. I really liked your concept, Esther, of including in the measurement of resilience the idea of anticipation. Because if it's about bouncing back from shocks, the more you can anticipate the coming shock, the easier it will be to bounce back. And we have a lot of things that we can anticipate, especially in climate-related shocks, flooding, droughts at the seasonal scale, climate change, but also market prices, urbanization in the wrong places, and so on. Your example of measuring stuff after a persistent blackout in Tanzania is a great way to measure what happens if something goes wrong, which I would love organizations like the Red Cross to learn more so that we can rapidly deploy stuff that can absorb that shock, reduce this stuff. So if we know that anticipating shocks can reduce the negative impact, the question is, what can we as academia do to better link with those who are making decisions on the field? How can we link our research with action, and how can we turn our research into action research so that Africa in 2060 brings even more good news? And the invitation is for those of you here in the public health BU realm. We have a project now in Tanzania about using new technologies, information communication technologies, to rapidly deploy solutions based on predictions. So if anyone is interested, I'm around. Thank you.
Okay. Anyone?
Thank you, Pablo. If I may say quickly, you're sitting next to one of my distinguished doctoral students, Aaron Strauch. He works in Tanzania. He's just completing his PhD on this very necessity to know how to make our academic output or the research work relevant to local people by engaging them, I think. But Aaron, you can say more about how it is you do it in Tanzania.
Alfredo, Melissa, anything on that?
I guess there is a limited ability, I think, for people, individuals, to respond to these shocks, even if you can predict them. You can know that it's a bad rain year, but I think that people live in countries in Africa may have a hard time adjusting to that and adjusting to changes in prices. So imagine that if there is that there is a crisis and people have to sell their livestock, everybody knows that if everybody sells the livestock, the price is going to decline, but you have no choice. You will sell it. You will, and therefore everybody will get the blunt of that shock. So, but it is an interesting point that from the point of view of the government, that there ought to be ways to absorb, to make predictions, and then the government agencies respond to those because the population itself will have a hard time doing so.
Other questions? I mean, on the resilience thing, I also sort of like the anticipation part particularly. But one use of that is can we better understand the shock before it comes, so that outside actors such as the Red Cross can quickly mobilize. The other, maybe even equally important or more important, might be, can we help create more resilience within the community itself, because ultimately the shock is really going to be absorbed by the community of its own resources and its ability to maintain that shock. And that's what Alfredo's example of the blackout. That's the difference between a community that has the resources to deal with it and not. Other questions, comments, issues, things?
On the way back over there.
Way back? You want to come up and... Yeah.
Hello, I'm Charlotte. I'm one of the summer fellows here at Pardee. I think this question is probably directed at Alfredo, because you were talking about creating medical structures. I'm quite interested about existing medical structures, like the use of traditional medicine. I haven't had anyone bring that up, and how that is shaping the future of health in Africa, because I know a lot of organizations have focused on retraining traditional medical healers.
Actually, maybe Melissa would be able to better answer that question than I am. I'm no expert on traditional medicine at all, but
I know in Tanzania specifically, the National Institute of Medical Research has worked closely with organized groups of traditional healers to try to do some basic public health training and also bring them into the, national health infrastructure a little bit more. I've heard, I don't know, for Tanzania and Kenya also, I've heard different things from people participating in the national health structure about how effective that has been. I think that it's happening and people are very interested in it and that it has potential, but at least the people I've spoken with in Tanzania and Kenya who worked for the National Institutes of Medical Research in both countries, there wasn't always a clear understanding of how these people were going to be absorbed in and what their role was going to be, especially in terms of medical research things. Sometimes, or initially, it was thought that a lot of traditional remedies, so herbal remedies and roots and things that have been used for many, many years and kind of oral knowledge passed down between healers could be tested for medicinal properties and using the scientific method in laboratories with trained researchers. And I think that has worked to a certain extent, but I mean, I think traditional healers also have an incentive to remain on their own because it's a different health structure that people seek out differently. So for certain illnesses, like in East Africa, people will seek out treatment in a hospital versus seeking out treatment from a traditional healer. So thinking of smashing these things entirely together, I think people would be slightly reluctant for that.
Can I tag on to that? I was fascinated by the examples that you used and the statements that you used from the mothers of these kids who were in these studies. So looking forward, what do you think will need to change to use what you're saying? There's a trend and it's going to keep growing, that we will have more and more of these medical experiments with human experiments in Africa. So how can it be used to better the medical infrastructure in Africa? Is that a legal issue? Is it to toughen international law? Is it sort of WTO and trade and services that comes in? Is it the Nuremberg? Is it sort of, that was the law that seems to apply now?
It's one
so
of the
international. Where does the change come from?
Well, it's one of the international treaties, and there are multiple international treaties that govern how medical research is supposed to be done equitably on an international level. And the problem with international treaties is that countries can sign on to them, but they're unenforceable. So unless a country chooses to enforce that on their own, no one can come in and arrest anyone for unethical medical research. Federal laws are different. So U.S. federal law for any drug that goes through the FDA approval process and that you receive like NIH money from has to fit U.S. federal law. How does that work in the field? Well, very rarely do you see anyone going out and policing projects and checking how well anyone has understood consent in a project. One, because it's really hard to do. Two, because most of these federal bureaus are understaffed and underfunded in the first place. And then three, we kind of have an incentive not to know because the more we look and if we find
Who's
it,
we?
Well, definitely the pharmaceutical industry, but also the FDA and even the agencies, the federal agencies like the Office of Human Subjects Research that is meant to police this medical research. I mean, it's bad publicity. It's not good news to find this stuff out. So I think that is what's likely to
therefore the
continue.
change will come because?
I think that part of the change is starting to happen because in the East African countries that I've worked in, the National Institutes of Medical Research have started to work more, bring a lot of applied anthropologists into their organizations to be doing better monitoring and evaluation as projects are going on and really trying to fine-tune their consent processes, especially working with non-literate populations and people who are not always familiar with Western biomedical systems. That's one way. So I think it's going to rely stricter policing is probably going to have to come from the East African or independent African countries themselves, being more circumspect about what projects they allow in. And I'm not necessarily very hopeful about that.
1 and 2. 1.
Hi, I'm Jill Costello. I'm with the Center for Global Health and Development at Boston University. Just further to that point, I'm going to play devil's advocate a bit. I think one, it's very easy to paint the pharmaceutical companies as the bad guys. But let's even leave them aside for a moment. Speaking on behalf of a number of researchers who do public health fieldwork and studies in Africa and other parts of the world, I think most researchers want to do well by their human subjects and aren't looking to abuse them and aren't looking to proceed with the study without informed consent. And you raise some very real, very tricky ethical issues. But the examples you gave, one study, a group started out and only offered primary care to their subjects. Mm-hmm. And so that was a perverse incentive, perhaps. The next example, they offered it to the entire community, and yet still there were these, built-in fears in the community that someone's going to take advantage of us. Now, whether that's post-colonialism or other issues, it's very real and it's really there. Mm-hmm. There's this concept in the world of development that is, let's not let perfect be the enemy of good. And so I wonder, when is it okay? And what will be good enough? And, would you advise stopping all medical research? Would you advise stopping this research on issues that are, apparently less relevant, although I would also question whether these are fully not relevant diseases, because if you look at the trends, and we're talking about Africa's 2060, heart disease, diabetes, cholesterol are going to be very real issues for this population. Mm-hmm. So it's about doing this in the real world. Where's the balance? Mm-hmm. And when is it good enough?
The changing disease profile is important. We have a paper published last year here at the Center on Obesity in Africa, which is not usually the first thing that one thinks of, but is in fact, as the food habits change, becomes an issue. Before I open up, maybe I can take another question, and then we can, gentleman here, we can open up to
Hi,
everyone.
Fred Folks, School of Management. 2 questions. What, if anything, have you heard about the role of the Gates Foundation in Africa, and are the lessons from their experience? And the others, in terms of drug research and pharmaceutical companies and getting candidates to cooperate and be involved, are the practices of these companies, to your knowledge, different in India or China than they are in East Africa?
Good question. Melissa?
Okay, I'll start with this and then come back. In terms of practices in another part of the world, I know that in Eastern Europe, it's, from what I've read about, I've never done research there, but just the secondary sources, is that there are kind of huge violations going on with informed consent in there, especially medical research going on in institutional settings like prisons and hospitals and orphanages and places where people can't always give fully voluntary consent because of the conditions that they're living under. I don't know how much better or worse that is than East Africa. I know from a historical perspective, looking at the 40s through the 60s, East Africa is very much in line with what was going on in Western Europe and even the United States in terms of medical research practices. There was nothing that I've found, and I spent over a year doing archival research and interviews in East Africa, that was more egregious going on at that point, that was more shocking than what you would have found in London or Amsterdam or even Boston at that point. So they were experiments that we would look harshly upon today, a lot of things with orphans, with people who were developmentally disabled, but those were very much in keeping with what was going on in East Africa. Today, I'm not certain about that. To go back to the earlier question about drugs not being relevant to East Africa, partly some of this research about diabetes and chronic health conditions, I think that that's true, that as African populations age, and especially a middle class develops in some of these countries that will live longer to develop these diseases, one of my concerns is cost and access. So even if the drugs are relevant and people have these diseases, I mean, how many people I interviewed said, oh, I have pressure, I have high blood pressure, and maybe there are drugs available for it in the country, but when they're so out of the price range of anyone or most people who need them, it's still questionable whether there's a real benefit coming back to the people who would be most likely to be drawn upon as a subject population. I do think that we can't let the perfect be an enemy of the good. And I definitely don't think from all the medical researchers I interviewed that I'd met malevolent people who were out to trick people into participate in research for the most part. But what I did find were people who were very pragmatic and wanted to get research done and felt very strongly about the work they were doing, that it was going to have a benefit. And many times I agreed with them. However, sometimes that deeply felt pragmatism meant that truly informed consent wasn't always gathered from people, or that indicators were coming back that people were not really understanding, yet the research progressed. And I faced this myself. I mean, I'm a historian doing historical research and doing interviews, and when I explained my own work in Swahili, going through consent forms multiple times, people would still look at me at the end and say, okay, so I have high blood pressure, so what drug can you give me now? And I would say, but I'm not a medical doctor. I'm doing research about the history of this. So did people understand, even me asking them a set of questions about what the risks were of answering, and did they understand my research? Boy, it's hard. And I know that medical researchers can spend a lot of time and energy trying to get populations to understand, but I think that when you offer a benefit to the whole community and all mothers are still participating because they think they're going to get different care, and when you offer it to individuals and they all participate and they line up because they want access to the care, both of those extremes to me show that there's still a lot of work to be done in protecting consent. And I think that consent has to be protected, even if that meant scaling back or slowing down medical research a bit. So,
either of you want to add anything?
The only thing I might add is maybe, Melissa, you found this also in your studies, or Alfredo, the importance of collaborating with local researchers. I found in my own team they are local people who do engage in the field work in collaboration with me. So what that means is the data that you produce belongs to them locally. They can use it. They feel ownership. So it changes the dynamics of why you might find more consent being meaningful if people are engaged at the local level. Local universities, maybe Aaron, you could say one word about how local institutions did it really worked in your setting, but we may not have time.
Sure.
Do you want me to check?
Yeah, sure.
All right. All right. In my research, I was working in both as a conservationist and as an anthropologist, and I collaborated with locals in both settings, but it was difficult to get cross-disciplinary participation within the country.
This was in
Tanzania.
Yeah, you'd probably find the same in Boston, but go ahead. It's not as if we are very good at that anywhere.
So there are definitely challenges, but using participatory research methods, engaging locals, whether they're experts or not, really helped generate a sense of community, that the research was a part of the whole community.
I was just going to respond. I'm not typically this cynical, but I mean, historically what I found is that in the 40s, 50s, and 60s, as African researchers started to be trained up through the university and became the lead field researchers for a lot of medical research projects going on in East Africa, practices sometimes became more coercive when Africans were in charge because they knew the language and the customs and the kind of idioms they could draw on that were much more effective in persuading people to participate than expatriate researchers could. So initially I started out with the hypothesis that research practices would have become far more ethical, in a sense, acceptable after independence and as large amounts of African researchers took over in the mid to late 50s. And what I found was that their British superiors would often write down and say, I'm so happy we hired this new local guy because he gets so many more people to participate than I ever could, and I don't know what he's telling them, but he convinces everyone, and they all go home, shaking afterwards. So I think it's a fine line, and I don't think that's necessarily what people are doing today, but I think that there's also there's that possibility.
Maybe this links back, and we'll start wrapping up in just a minute, to the incentive thing and this little quip you threw in, that as we start figuring out incentives better, we might actually get into more trouble than we think, because we actually start understanding them very, very well. So this goes back to Norplant in Indonesia, this goes back to population control in India, giving you a transistor for a vasectomy type stuff. What sort of, is there a link there, or am I
see that
exaggerating it?
No, I think that.
I hope I am. But
well, potentially, I think there is a link. I mean, we're pushing this idea of incentive payments. This idea that started with Progresa, which is, if your kid has gone to school every single day, then at the end of the month you get a little amount of money, and then we're pushing into, let's change your sexual behavior with it. Sorry to butt in, but because I'm really trying to figure out this practical question: what do we do to fix it? Right. So I keep gravitating to this idea. Okay, if we're doing these things wrong, what do we do that will get it right? How do we get incentives right? You apply it in. I think you really look at the ethical aspects of it, and you try to apply to make sure that they're ethically sound, so that they're not coercive. But at the same time, you also make sure that you do try to apply it in many dimensions, because people do respond so strongly to these incentives. And so I think there is space for that, and it's just an issue of, to some extent, of exploration and figuring out where are the places where you could apply this, and where are the places where you should not. And I don't have an answer for that, because this is for instance, I just heard somebody whose ongoing research is to use these incentives not to pay people to get tested, but provide them insurance in case, if they go and get tested and turn out to be positive, this is an insurance payment that will provide the money to cure that disease. So that's an interesting way of doing it, to remove, that provides an incentive, but perhaps without the ethical implications.
Has a tangible benefit to it.
It's a tangible benefit without the, the ethical implications that changing behavior might have.
We'll have a last question there, and then we'll leave it out.
For Melissa, how does this differ from a college student going into a sleep research center to actually get paid $1,450 for a week sleeping in the lab, despite how many probes are going to be placed up various parts of their body? And how does it differ from somebody who has melanoma just simply going, please, anything you do to me is fine? Mm-hmm. So are we looking at what goes on in this country as a different mindset that's actually being used for what goes on in Africa?
In some cases, I think it's very similar to what's going on here. And one of the things that I've written about and did a lot of interviews on was this idea of therapeutic misconception. So the idea that it's prevalent in the United States and Western Europe, that you would sign up for a research trial believing that it's going to benefit you therapeutically, it's going to make you better, not that it's in the benefit of science, that the goal is to generate data. So a person with end-stage cancer who goes to the doctor and says, enroll me in any trial, get me any experimental drug, when anthropologists and sociologists have gone back with those groups and done questioning, what they often find is that the consent is not informed understanding and voluntary. It's desperation. It's people believing that medical research will cure them, that anything is better than nothing. And in many cases, or from a public health perspective, you look at those situations and you say, you should not allow those people to participate in that research because they're not in a position to give free consent. They're not clear about understanding the risks and benefits. They believe it's going to cure them. Many of the same things pop up in East Africa, where people say, I'm enrolling in this trial because it's medicine, it's dawa, and it's going to make me better. I think sometimes what's different is that end-stage cancer patient in the United States has probably had primary, secondary, tertiary care and run out of options, so they're looking for anything, they're grasping at straws. In East Africa, where you don't have access oftentimes to basic medical care, you could say that participating in a drug trial may actually benefit you therapeutically because you may get cured for another minor condition that's going on. So there are some similarities definitely in how people think about it. Some of the limitations I think that East Africans have that make giving the informed understanding and consent, voluntary consent harder is low literacy rates, low education rates, and less familiarity with Western biomedicine. So that's not saying one system is better than another, it's just that a lot of people I interviewed don't necessarily think blood circulates through the body in the same way that we think blood circulates through the body. So even the mere act of giving blood is conceived differently and has a different amount of risk to it than the way anyone walking in here would conceive giving a drop of blood to be a low-risk procedure.
Thank you. As I thank you, let me just ask one question and get a very brief answer from each one of you, and then we wrap up. This is again pushing one last time on sort of ideas of what can change, what can do. Maybe this is the engineer in me, wanting to change things for the better. If the goal is 50 years from now, better health in Africa, in your area, amongst the things that could be done, what do you think should be done? So amongst the practical things that could possibly happen, what do you think is the most important thing that should be done, for example, to enhance resilience?
I think to understand the complex systems and subsystems where health and social policy is made, how it's implemented, that's something we can do and we should be doing. And maybe just a brief comment related to that, how you can do it, to connect with a question that was asked earlier about traditional practitioners. How do you integrate them? I have seen in my experiences that the traditional birth attendant is one of the most common manifestation of the traditional practice. She will look after the expecting mother from beginning to end, not only giving advice to do with health, but also advising her on emotional and other practical issues. So she becomes part of the support system. In Eritrea, I found training the traditional birth attendants was highly effective because they have safe delivery kits. And so when they deliver babies, they're much more, they have actually reduced the under 5s mortality rate by practices like that, which integrates community sensibilities with the medical or the top-down systems. So systems and subsystems can function in a non-linear but functional and productive way. I think that's something we can visualize for 2060.
Alfredo, what should be done?
Well, you know, as I said, in the long run, what the bigger determinants are going to be, you know, the growth of the overall economy and the organization of healthcare systems. And those are things that are organically going to grow. So I think a lot of these things are going to happen naturally. In the short term, you know, these inventive interventions, I think they do play an important role. And the role of researchers on the ground doing research for medicines and public health experts doing the research and trying to figure out what works right now is important. So, but in the long run, it's going to be management of healthcare systems, which is a function of the management of the overall economy.
Melissa?
So I think medical research definitely has improved health in East Africa over the past 40, 50 years, and I think it has the potential to continue doing so. I would say for the future, the biggest thing that ought to be paid attention to is that we need to enforce our international and national laws more strictly to provide
We being?
Both the United States government when they're American researchers and African national governments when the research is happening within their territories to protect subject populations, both for informed consent, but also for really thinking about risks being borne by subjects and the benefits being delivered to these populations. And I think if that means slowing down the pace of medical research, that is a trade-off I'd be willing to see.
Thank you all. Thank you very much for some very very interesting. Before we wrap up, if I can just have one comment. I was intrigued that we didn't get an answer to the Bill Gates Foundation question, which is rather interesting. Not to you guys don't work on it, but which is interesting because every time we've had a panel on anything dealing with health, that actually has been one of the things at the center of that. And I think that's a question of what is the type of intervention that can have an impact, because there a lot of money is being put on a particular type of intervention, which interestingly was also not in, at least the de facto answer might have been that when asked what would work, none of your interventions was of that type. Let's go and find the magic solution. But I will continue to search for the magic solution, whether it's pharmaceutical or not. Thank you everyone for coming.